Hello, myself Dr. Manisha, Assistant Professor, Faculty of Physiotherapy Department in RPIIT Technical and Medical Campus. Welcome to our YouTube channel RPIIT Academics. If you like the content of this channel, please like, share and subscribe. Today's discuss about the fracture of the shaft of the humerus. This is a common fracture in patient at any. It is usually sustained from an indirect twisting or bending force, as may be sustained in a fall on outstretched hand or by a direct injury to the arm. Now we can see in the picture displacement in fracture shaft of the humerus, lateral angulation, tendency to keep the arm close to the body, and twisting displacement. Relevant anatomy. The humerus is a typical long bone. The upper half of the shaft is roughly and begins to flatten in its lower half in the anteroposterior direction. The deltoid muscle is inserted on the deltoid tuberosity on the anterolateral surface of the bone just proximal to its middle third. The posterior surface is crossed obliquely by a shallow groove for the lateral nerve. The humerus is surrounded by the muscles. This has the following clinical relevance. The incidence of compound fractures is low. The union of fractures occurs early because a bone so well surrounded by muscles has a rich periosteal blood supply and some degree of malunion is masked by the thick muscle of pathoanatomy. A humerus fracture can be considered a prototype fracture because it occurs in all patterns transverse, oblique, spiral, comminuted, segmental, may be closed or open, and may be traumatic or pathological. Displacements are viable. It may be an undisplaced fracture or there may be marked angulation is common because of the abduction of the proximal fragment by the deltoid muscles. This angulation is further increased by the tendency of the patient to keep the limb by the side of his chest, resulting in adduction of the distal fragment. Often distraction occurs at the fracture site because of the gravity. Diagnosis. X-ray करा सकते हैं. There may be wrist drop, radial nerve is injured. Treatment. Most of these fractures unite easily. Anatomical reduction is not necessary as long as the fracture is stable. Some amount of the displacement and angulation is acceptable. This is due to following reasons: limitations of the motion because of a moderate malunion in angulations or rotation goes unnoticed because of the multi-axial shoulder joint proximally. Some amount of shortening goes undetected in the upper limb, unlike in the lower limb where shortening produces a limp and the bone is covered with thick muscle so that the malunited fracture is not noticeable. Unlike the tibia where malunion is easily unstable, strict immobilization is not necessary. The aim of treatment is pain relief and prevention of lateral angulation and destruction. It is possible to achieve this by conservation means in most cases.